My pleasure to introduce our speaker this morning to the combined OBGYN pediatric grand rounds. Dr. Sue Wang is a graduate of the University of Miami School of Medicine, and while she was there, she also received her master's in public health from the Johns Hopkins School of Public Health. Following her medical school graduation, she did her internship and residency at Georgetown University Hospital and was the chief resident for the medical needs program there after she completed her residency. She has had a lifelong or career-long interest in public health, and she initially was the academic intelligence service officer stationed at the FDA in Washington, D.C. area. And then most recently, prior to coming to St. Barnabas Medical Center, she was the Assistant Director of Medical Affairs at the Charles B. Wang Community Health Center in New York City. She was the Hepatitis B Program Director there. She's the Medical Director of the Center for Asian Health here at St. Barnabas Medical Center, and has obtained a number of grants in funding for programs. Initially, the CDC grant in conjunction with the Charles B. Wang Community Health Center, a funding of $1.06 million over 3 years, and then following that grant, here she's obtained a Gilead Focus grant for HBV HCV screening at St. Barnabas Medical Center in the emergency department and throughout the medical center. So without further ado, Sue.
Thanks, Dr. Ye. Good morning, everybody. I'm very happy to be here to talk about perinatal hepatitis B transmission, gaps and opportunities in the era of global elimination. So I'm going to tell you a little bit about our program real quick. So I'm the medical director of the Center for Asian Health. So we launched in 2013. Basically, our goal is to serve the growing Asian population in New Jersey, and we do that through a couple different ways. We have a primary care practice with a number of specialists that rotate through our office, and you can see the staff here. We do a lot of patient navigation, and my staff is here in the front, and they really help people kind of navigate through the very complex U.S. healthcare system. And then we also conduct a lot of community outreach and education to the community. So come visit us. We're at Florham Park. We used to be right across the street at Atkins Kent, and then we are moved to Florham Park. And I take everyone, not just Asians. So, and I actually see a lot of staff at the hospital as patients. So we're open to everybody. And this is a really nice building. It's a multi-specialty site with a lot of primary care doctors and also internists. All right, so just to start, no disclosures or conflict of interest, except I did have 2 kids at St. Barnabas. I don't know, that might be a conflict of interest, but these 2 younger ones were born here. All right, so we're going to talk about hepatitis B today, and many of you know what we call like the alphabet soup of viral hepatitis, A, B, and C. There's also hepatitis E, and these actually all together are the 7th leading cause of death in the world. So, and what's really exciting now is that we actually have the tools to eliminate viral hepatitis. We have vaccines for A and B, and then we have cure for hepatitis C. So I'm going to show real quick this video about what this means for us being in the era of elimination. When you've been using a Mac all night, all of a sudden you can't use. Here we go. So I just wanted to start off with that, just to give everybody kind of the global picture of what we're talking about. We're talking about eventually eliminating viral hepatitis within by 2030. Oh, I knew that was going to happen. Sorry. And it's kind of, I think we forget sometimes that this is possible, that we can actually eliminate disease. But if you think about smallpox, we are able to eliminate also. So, but we definitely need a lot of work to get to that point. And what I'm going to show you is that of what some of the gaps are at this point. So in the U.S., liver cancer, hepatocellular carcinoma, is actually the fastest growing cause of cancer-related death in the U.S. And this is definitely alarming, because while rates of breast cancer, prostate cancer, and other cancers are going down, liver cancer is actually on the rise. And this is from MMWR report from the CDC. And the survival rate remains very low, actually, about below 12%. So this is largely due to unscreened and untreated chronic viral hepatitis. So that's viral hepatitis B and C. So we definitely still have a lot of work to do. Today we're going to focus on Hep B, and I'm going to focus on perinatal Hep B. So a lot of people don't know it's the most common bloodborne infection in the world, 10 times more prevalent than HIV, the #1 cause of liver cancer in the world, and it's a major health disparity in the U.S. So more than half of the people infected are actually Asian, but not just Asian. A lot of them are foreign-born from other countries. So Africa is actually a big one, Latin America, and even Europe and the Caribbean. So even though on a whole in the U.S. the prevalence is low, but because of migration patterns, you see that there's actually, based on a lot of immigrants coming from Asia and Africa, those are the target populations really that are affected by hepatitis B. And so why is it so important really to focus on perinatal Hep B? Because mother-to-baby transmission of Hep B accounts for almost half of all the people who get hepatitis B. So I know there's a lot of confusion over all the hepatitis, and so a lot of times it gets lumped with Hep C, and I hear people say, oh, if you're not a drug user, you don't have to worry about hepatitis B, but actually a lot of it is actually mother-to-child transmission. So, and what the concern is that when you get infected as an infant, you're more likely to develop the chronic form. So we know there's acute hepatitis B and chronic. If you're an adult, so if you're over 5 years of age and your immune system is intact, largely you will actually resolve hepatitis B. So less than 5% who are adults actually develop a chronic infection. But those who get it in infancy and young childhood are likely to develop the lifelong form. And the problem is that this can lead to cirrhosis, liver cancer, and obviously they're a reservoir of ongoing transmission to other people. So this is why it's so significant, is that it's largely asymptomatic, and those who do develop it in infancy become lifelong and then eventually are at higher risk of liver cancer or liver failure. So this is kind of looking at all the steps that it takes to get to this ultimate goal of elimination. And birth dose vaccine is a critical part of it, along with a lot of other things. We're doing well actually in infant vaccines. So in terms of completing all 3 vaccines during childhood, we're doing well. But in terms of actually giving the birth dose, we still have some room to go. So this is, if you look at all the different measures, this is childhood vaccine at the top, and we're doing really well with that worldwide. Mother-to-child transmission, the birth dose worldwide is only given about 30% to all babies. And then when you even look at diagnosis and treating those with Hep B and Hep C, we're still at the starting point almost. So we do have a lot of work to get to 2030. All right, so the great thing about hepatitis B is we have vaccines. If you think about it, we don't have vaccines for HIV or Hep C. So this is really the game changer in terms of eliminating Hep B. And so this is kind of his historic timeline of what's been around. And so when you look at since 1984, we've been giving Hep B vaccine and HBV within 12 hours for infants whose moms have Hep B. And then it was added to the infant vaccine schedule in 1991. So those of us who were born before 1991 did not get Hep B vaccine as kids. But because we're healthcare workers, we have been immunized. But largely, a lot of adults who were born before 1991 are not immune, actually. So, and then starting in 1999 and over time, the universal birth dose for all babies, regardless of the mom status, has been adopted by almost all professional organizations that are that recommend vaccines or have anything to do with infants or children. So this just shows you how significant our interventions have been. So Hep B virus was discovered not that long ago, and in the time it was discovered, we started screening blood banking pretty soon, developing a blood test. The vaccine was licensed in the 80s, and as we started screening pregnant women and started the infant immunization program, you can see that the rates of acute hepatitis dropped pretty significantly. But we're not quite there yet. We still have about 1,000 infants a year infected in the U.S. And if this were HIV, it would really be something that would be very concerning at this point. Our goal is by 2020, the goal is to get to zero. So, and why is that? So largely, actually, a lot of it is from failures of the healthcare system or medical errors, where the mothers were not screened, or they weren't identified at the delivery hospital as having Hep B. We've definitely heard of errors in transcription because there's still manual transcription involved where somebody who had Hep B positive, but the transcription is actually just put in negative. And so the mother was not identified as having Hep B. Vaccines not always given properly. And then in the end, when they see the pediatrician, they may not get the vaccine serology test after they finish the vaccine. And the other element of transmission is because of biologic failure, in that the mother has such high viral load that they actually the baby still gets Hep B despite the vaccination. And there's a growing use of antivirals during that third trimester that can reduce the risk of transmission. So this is some interesting modeling that was done looking at the interventions that we have and what it will take to get us to zero, or the number of new infections a year. So status quo is this blue line, all right, where we are in terms of, globally, vaccine practices, birth dose. If we are able to implement 100%, more than 90% infant vaccine coverage, this is how the line goes, right? So it does go down. Birth dose coverage, if we start vaccinating over 80% of all babies, not even 100%, you can see that it drops pretty down. The drop is actually a lot more significant. And then if we start doing antiviral treatment or more maternal to child transmission prevention, you can see that we get down closer to zero even faster. So it just shows you the impact of all these strategies on the global effect of reducing new infections. So this just came in. This was published this month in Pediatrics, and this is the updated guidelines for the birth dose. So up till this year, last year, it's been recommended that the birth dose has been recommended before discharge of the hospital for the infant. But now the data is showing that actually the sooner we give the baby the vaccine, the better the protection is. So the recommendation is now within 24 hours of birth. So there's definitely new strategies that have to be developed and protocols that have to be developed so that we can actually do that and meet what's now considered standard of care. So, and this was AAP putting a statement out that was already recommended by CDC and the ACIP. So we could say here, it used to say there was an option to delay the first dose until the first newborn pediatric checkup, but now we're saying that it should be within 24 hours to maximize effectiveness in preventing newborn infection. So and this is all to help us to get to the goal of zero babies having perinatal Hep B by 2020. All right, and one other thing they mentioned is that something that's happening that will probably continue to happen is that actually you saw that nice downward trend I showed you of acute Hep B really going down. But we're seeing at the tail end, like recently we've been noticing actually an increase in acute Hep B because of the opioid epidemic. And so this is a case report in MMWR where they did some surveillance and noticed that in 3 states, actually the trend of acute Hep B is actually going up. And this was noticed to be in non-Hispanic whites, age 30 to 39 years, so they may not have gotten pediatric vaccination. And the notable thing is that they were injection drug users. So this is even more important for us to be doing the birth dose, as some of these will actually be of in childbearing age also, this population. All right, so I'm going to go over kind of what we consider the roadmap of pregnancy care or perinatal Hep B. And I show this picture because it's very complicated healthcare. And perinatal transmission, I think, is one of the more complicated kind of disease states. And when you try to do an intervention, I mean, as kind of an example of what we have here, it involves OBs because you have people who are taking care of the mom. And then you have, so taking care of the mom during pregnancy. And then you have the whole delivery team when she shows up to the hospital. And then you have the pediatric team that takes the baby in the hospital, and also the pediatrician who then sees the baby afterwards and needs to complete the vaccine and do the serology test. So when you think about how information is transferred this day and age across all our different practices and hospitals, we all know we're not all connected, right? I mean, even getting data for me from the hospital, now we have some information exchange. But if I were trying to get data from an OB office, we all know I'd have to get on the phone and I have to ask for a release of information. So information is not as direct as we'd like for it to be. And so a piece of information like the mom's surface antigen test does not flow easily. And so what happens at the downstream is that the pediatrician who has the baby does not always know that that baby has a mom who has hepatitis B. And so this is why coordination of care is really important and key to preventing Hep B, and also why there's so many errors that can possibly happen. So what are the standards of care? So at this point, every pregnancy has to be tested for surface antigen. This has been recommended since 1988 by CDC. And we found that you had to universally screen all pregnant women because if we do risk factor-based screening, kind of looking at the mom and saying, oh, do I think you're at risk for Hep B or not, we missed a huge chunk of people who actually had hepatitis B. And so this should be done early on in pregnancy, and we're doing well with this. Almost more than 95% of all pregnancies are tested for hepatitis B. And so what CDC actually developed not long ago is testing panels with all the commercial labs, LabCorp and Quest, and there's a certain code that is used to denote that this is a pregnancy-related hepatitis B. And the reason is all pregnancies that where the mom is Hep B are actually case managed or reportable to the health department. But the health department gets so many, like hundreds of Hep B tests, and they don't know from the lab which one is a pregnancy. And so using this code helps them identify that this positive test is connected to a pregnancy, and they can focus on doing case management for that test and for that mom. So, and this is specifically for just a surface antigen test. So just as kind of more background, if you're doing routine Hep B screening to look also to see if the patient is immune or has been exposed, you do a panel of 3 tests. So besides just a surface antigen to detect infection, you also do a surface antibody. And if that's positive, that means the individual is immune. And then you do a core antibody to determine if the immunity is from past infection or if they're immune from vaccination. All right, so what's the next step? If the mom has hepatitis B, is surface antigen positive, then the next step is actually to do an evaluation of the Hep B. So that means doing a Hep B DNA or viral load, the E antigen status, and liver function test. So usually that's done, so it should be done soon after the initial diagnosis, and then repeated again at around 28 weeks to find out if the mother needs possible antivirals. So, and this is the natural course of hepatitis. And I show this because to show in terms of what happens over time. So if somebody has hepatitis B acquired from the mother, their first state is often what we call the immune tolerant state. So that just means the body does not recognize the virus. It thinks it's part of the body. It does not mount an immune response. So oftentimes during this time, this is often in the teens or childhood, the viral load is extremely high. It can be in the billions, 100 millions. And so that person is actually quite infectious. And it's not until often their 20s or 30s that their immune system mounts a response and then realizes the hepatitis virus is in the body and actually tries to eradicate it. So during that time, you might see liver function tests fluctuate and the viral load fluctuate. But you can tell during this time, this is when people are often having babies and getting pregnant. So this time you might be seeing moms who actually have a decently high viral load. But this also just shows you that Hep B is a very influx kind of virus, and we've kind of been accustomed at times to using the term carrier. Oh, that person's just a carrier. And I tell people that's actually a really false sense of security because the viral load at any time can start increasing. The liver function test can start. The liver function can also fluctuate. So people with hepatitis should always be monitored at least yearly. So there are all these great algorithms that CDC has developed just showing you that if somebody is infected, that you want to make sure all the household contacts are also screened and tested for. It's a great opportunity to make sure the spouse or the partner is immunized if they're not already immune. And then the next step is to order those tests I was talking about. And depending on what the test results are, they can be monitored or they should be referred to a specialist, and it may be the maternal fetal medicine physicians, and Dr. Miller's practice actually sees a fair amount of these hepatitis B pregnancies, so they can continue to follow those cases. And so what we're finding, though, that the linkage to care is definitely an issue, and that a lot of pregnant women who have Hep B are never referred for a full evaluation. So in one study of the Perinatal Hepatitis B program, 15,000 pregnant hepatitis B moms, only a fifth actually had an e antigen test done or a DNA test. And then of those, only a third reported getting care for the Hep B itself during their pregnancy. So we have a lot of work to do. And I've heard some people say, oh, but if their liver function tests are fine, you don't need to do anything else. That just means everything's fine. And that's not true. You do need to check a viral load because that is what is going to put the baby at risk for getting Hep B from the mom. So and it's a good chance to get the mom into care for Hep B. It's really not just for the pregnancy, but the mom herself needs to get care for Hep B starting during the pregnancy and ongoing. So what we started doing at Charles B. Wang Community Health Center is saying, you know what, there's so many possible things that can happen that can go wrong with the healthcare that we should also really empower the mom, right? The mom is the one who cares the most about this pregnancy, about her baby, and so she should know what to expect. So we created this roadmap, which I think we have copies in the back. So on your way out, you guys can definitely feel free to pick them up. And this is actually, we have it in Chinese, we have it in simplified and traditional Chinese. And this just shows the mom this is what to expect. You should get these blood tests during pregnancy. Make sure at birth, tell the staff at the hospital you have hepatitis B, and the baby should get 2 shots, the HBV and the Hep B vaccine within 12 hours. And then it shows them, completing the vaccines, and then they should get a little serum here that the baby should get the surface antigen and the surface antibody test, 9 to 12 months actually. All right, so this is a table showing what are the outcomes of infants. So in terms of those so this is mothers who have surface antigen. So these are the infected moms. Okay, so for moms who are e antigen positive, showing high levels of replication, if there is no vaccine, and this is where we were before the days of the vaccine, the large majority, 70 to 90% of babies born to these mothers would get Hep B. So it's almost like a sure thing. So, but now with the vaccine and HBV, and if they complete the vaccine series, we reduce the transmission rate down to 9 to 15%. So it's not zero. You still have almost about 10% of babies who are born to moms with the e antigen still getting hepatitis B. And then if the mom is not e antigen positive, before vaccine, it was 5 to 30% chance of transmission. And we've now reduced that with vaccine to less than 1%. So we do well in this population. So you can see it's this population with high replication, the e antigen, that's positive. And some of these other studies that have been coming out recently really showed that the difference is not just the e antigen itself, it's actually the viral load. So this study looked at quite a large group of 1,800 pregnancies, and they looked at 1,200 that were included in the study. And when they followed the babies, they found that the infected babies, these are the blue ones, were born to moms who had viral loads over 10 to the 6 copies, which is 200,000 copies per ml. And those whose moms had less than 10 to the 6 viral load did not get infected at all. So this is why now the recommendation is that if the viral load is over 200,000 copies, that mother should be considered for antiviral treatment. So and then in terms of what are other scenarios, we definitely have babies or moms who are already on antivirals before before their pregnancy. And so that becomes a question: do you continue the mom or do you discontinue? And the second scenario would be just specifically treating the mom during pregnancy to reduce the risk of transmission, but then stopping it after the baby is delivered. So, and there are several studies showing that when we do start the treatment in these high-risk moms, we can actually reduce the risk of transmission. So this is one in using lamivudine, where you can see that we were able to reduce. The blue is the lamivudine, the red is the placebo, where the rate of transmission decreased with the lamivudine. This is tenofovir, which is now the more recommended when it's category B. And this was a large study that was done in China. This was actually randomized, which some people brought up the ethical issue of that, but at that time we weren't sure whether or not tenofovir antivirals really worked. But in this randomization, you can see that the control group definitely had higher rates of Hep B infection compared to those who were on tenofovir. So this is the algorithm that has been proposed now. Based on this viral load. So those who have, the moms who have viral load of over 200,000 are considered at high risk, and you can consider any of these three medications, tenofovir, lamivudine, or tolivudine during the third trimester. And then those who are not are considered low risk, but they should obviously still get the HBV and the Hep B vaccine. So this is just showing that obviously there are always questions about any issues or teratogenic with using the antivirals, and there's a antiretroviral pregnancy registry, and there's actually quite a number of patients in this because of HIV. And so tenofovir has been used in HIV for a number of years, and when you look at the rates of birth defects, it's no higher than what the baseline birth defect rate is, which is 2.7% of all pregnancies. And with this is lamivudine, tenofovir. Tenofovir is actually even lower at 2%. Lamivudine is 2.8%, but it's not a significant difference. So this is stuff I always go over with moms before we start the antiretrovirals. So, and then there are different guidelines across the world. APASL is the Asian guideline, AASLD is the American guidelines, EASL is European, and they have different recommendations for what the drug of choice is. Tenofovir is a common one across all of these. And in general, the time to initiate is about 28 weeks of gestation. So the next step is when the mom is ready to deliver. She goes to the delivery hospital. And the key thing at this point is identifying the women with hepatitis B, right? So if everything goes well, her records should have been sent over from the OB practice to the delivery hospital. But that doesn't always happen. Say the patient delivers early before her chart goes over, or there's a clerical mismatch, and you hear this all the time. The mom's name is misspelled a little bit, and so then her records do not go up with her to the delivery unit. Or say she goes to a different hospital, maybe she's visiting somebody, and so then her prenatal records do not end up at the hospital. So these are all issues that could possibly happen where a Hep B positive mom does not get identified at the delivery hospital. This is why it's so important that we have really good health informatics, and that the mom herself is aware of her own status. So this is a CDC's protocol for the procedures in terms of identifying a mom at delivery. And I'm going to have Melissa in a little bit talk about our procedures here at the hospital and what we've done to try to improve identification. But this is great to have as a reference guide, around it. It talks also about whether to rescreen the mom if she's got other risk factors at the time of birth, and then also whether to vaccinate, and looking at the weights, for all the preemies that are less than 2,000, what you do in that scenario. So the Immunization Action Coalition puts out a great resource in terms of best practices, and this is something that we followed a lot of. So this is the checklist, looking at whether the right tests were done, whether the mom needs to be rescreened, and whether the information is conveyed to the nursery. So this is a protocol based on the new recommendations that just came out. So this is something for us to revisit internally also. So they've done studies looking at hospitals and their policies, and this was done looking at 192 hospitals. And what's sad to see is that of the babies born to the Hep B positive moms, only 62% actually got the HBV and Hep B vaccine. We all think that that should be standard of care. So it's surprising to see that it can be so low. And what they found is that the strongest predictor of birth dose vaccine is actually having a hospital protocol. And even those who had the unknown status, only about 50% got their vaccine within 12 hours. So, and on a whole, this whole low issue of universal birth dose is actually what we feel like is keeping us from eliminating the goal of perinatal Hep B transmission. So a lot of times we feel like in the U.S., oh, we must be doing pretty good. We're like, leading country in many of the indicators. And in the overall U.S. rate of Hep B birth dose is 69%. And when you compare us to other countries in Latin America, we're actually lower. We're lower than Mexico, Brazil, Cuba, Costa Rica, Dominican Republic. So I show this to show people that we're not doing a great job in the U.S. And then when you compare that to other vaccines given at birth or injections, we do well in vitamin K. So this is something that we should try to aspire to get it to close to what vitamin K is at 96%. So, and then just real quick, as I talked about with the baby, they have to get the vaccine at 9 to 12, the serology test, the surface antigen, surface antibody at 9 to 12 months. And what we found in those case-managed infants in the CDC program, only 63%. And what happens a lot, because we work with the nurses who call and follow up with the pediatric practices, and they say the pediatricians don't know to order it, or they don't understand why it has to be, or they forget, and there's a lot of difficulty in actually getting that test done. And so when you don't do that test, you don't know whether the baby is actually infected or not. So that's why I feel like even though we think 1,000 babies are infected, there's a chance it could be more because not every baby is getting this test. And those who are not immune, if they're not tested, don't get the second series. So the recommendation, and some of you may have gone through this yourself, if you're not immune after the first round, you're supposed to get a second round of Hep B vaccines. And the mom should get ongoing care because there are often hepatitis flares postpartum. So this is just showing that Hep B pregnant moms positive moms can breastfeed. It's recommended by AAP and WHO. Once the baby's vaccinated, that she can breastfeed as long as her nipples are not cracked and there's no bleeding. Okay, this is just data showing that there was no significant difference in babies getting infected, whether the mom breastfed or not. So it's all not significant. So how are we doing in New Jersey and at St. Barnabas? So I love this. You get hepatitis B, why not hepatitis A+? So this is my segue into how are we doing? What's our grade? How are we doing with vaccination? And this is New Jersey. New Jersey is 47th out of 50th states. So we're at almost the very, very bottom of doing birth dose, which is really astounding and really kind of tragic given how diverse we are as a state. We have the 4th highest population of Asian Americans. And so we know we are a state of very international people, and therefore we have endemic people who come from endemic areas of hepatitis B. So we should really be at the top. We should not be at the bottom. All right, and then how are we doing as a hospital? So we get a report card from the health department, and they just sent this over to us in July. So we have 36% of babies who get it within 24 hours of birth. So this is before the whole the new recommendations came out. And in terms of who gets it before discharge, we're at 70%. So we're right out with the national averages, but we have some work to do for the 24 hours. So this arrow is us, and this is looking at all the hospitals in New Jersey. So you can see we're below the state average. The red line is the Jersey state average, and we're below that. So I thought we were doing pretty good when I saw the 69% were at national average, but we're below the state average. So this blue is the before discharge, and then the purple is the 24 hours. So if you can see, even a lot of the other hospitals are already doing it before 24 hours. And this is how we do across all the RWJ hospitals. So St. Barnabas is in red. New York Beth Israel is doing really well, almost 100% birth dose before discharge, and almost half within 24 hours. So we are kind of in the middle. So it's doable. I mean, I show this to show people that it's doable because other hospitals are doing it. All right, so I'm going to turn it over to Melissa. She's going to talk a little bit about what we've been doing kind of over the past couple of years and what we hope to do in terms of improving our stats at St. Barnabas.
Yes. Good morning, everyone. For those that don't know me, my name is Melissa Gonzalez. I'm the clinical coordinator on the mother-baby unit. And Dr. Wang just asked me to share basically what we do here at St. Barnabas. So back in 2016, based on recommendations and statistics on how to prevent perinatal hepatitis B transmission, we developed a policy on what best practice is to prevent the perinatal hepatitis B transmission. So one of these areas for improvement here at the hospital was to improve the hours that we test for hepatitis B. Prior to the implementation of the policy, we only tested from 7 to 3, 5 days a week. So if we had a patient come in during the weekend, or if we had a mother deliver, after 3 o'clock, there was no way to run a test on a mom that either had unknown hepatitis B or who was at high risk and we needed another test done. So with that, we worked with the lab, we collaborated with the director, and we had that change. Now the lab is testing from 7 a.m. to 11 p.m., and that's now 7 days a week. So now that allows us to have testing done and still vaccinate a baby if the mom is positive for hepatitis B within those 12 hours. Another thing that was done was a policy was created for the birth dose standing order. So basically the policy states that every baby born here, we would vaccinate, or we would offer the vaccination within discharge. But as Dr. Wang stated, now the policy has changed. Now the best practice is to administer the vaccine within the 24 hours. So hopefully we can collaborate with the pediatricians and with our nursing staff to implement that here. And what some hospitals are doing is actually giving it with the vitamin K and erythromycin. They do it 1, 2, 3, vitamin K, erythromycin, and hepatitis B. Boom, 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 done. This way we can ensure that all babies get the hepatitis B, and that also that it's given within the first 24 hours as well. And another thing from a labor and delivery standpoint is when we receive the information regarding the maternal history, we ask to see the mother's actual record of her hepatitis B lab. The reason being is there could be an error in transcription. It could be, just a simple, mistake on report. So when we receive the mother, we want to make sure that we have an actual lab result on the baby. This way there's no discrepancies. There's no confusion as to whether the mother is hepatitis B positive or negative. And another thing that we're doing is increasing our education and awareness with our nursing staff and with our patients to, explain to them the importance of the vaccine. Because as Dr. Wang stated, it's such a, easy thing to eliminate if we, follow the best practices here. So hopefully we can implement everything, the current practices that we have now, and go forward and hopefully eliminate the disease. Thank you.
Thanks, Melissa. So yeah, our nursing staff has been really, I think, motivated about this. The postpartum nurses are really trying to do more. A lot of it, I think, is just making it standard of care. So it's just like seatbelts and everything else. At first, there's a little bit of resistance, but once it becomes adopted, it's just like vitamin K. People hardly ever think about it anymore. Then we've gotten to that point where, we can really reap the benefits of, these public health interventions. So the other thing I'm really excited to announce here is this project that we have that we received a grant from the Department of Health through the New Jersey AAP. And they wanted us to work on developing a perinatal Hep B webinar, which would go widely out to New Jersey practitioners to try to boost our numbers as a state. And so we had a really good time interviewing different staff at St. Barnabas. Rutgers University has a web design team, which for some reason is housed in their agriculture department, and they helped us design this really cool web module. And so the next step is actually we're disseminating this through the New Jersey AAP members. There's going to be postcard mailings, and we want you guys to kind of give us feedback on this and help us disseminate this too. We want to be kind of the pilot program here at St. Barnabas that we can then launch to other hospitals in New Jersey. So this is kind of my first grand rounds talking about this, but we'll also go to other hospital to actually do some of this education. So this is kind of what it looks like just on the first page. It's on this Rutgers training course website, and it's fun. It's interactive. They did a really good job with the graphics. It's a lot easier than just listening. It's interactive, and this is the link for it. If you guys want to write it down, it's pretty easy. They made a bit.ly out of it. And we have some, so it has different sections. It's got little quizzes in it to kind of keep you interested. And once it goes live, we can send the link around to people as well. And we have some stars in here. So Dr. Lovenheim, we interviewed one of the pediatricians here to talk about how he uses the standing order. What we're finding is for the most part, pediatricians are doing great, with the standing order, but there are some pediatricians who prefer to do it in their office and are actually unchecking the standing orders. And so that's something we're trying to discourage, given that this is now the standard of care. So we have Dr. Miller here, and I'm just going to show a really quick clip of him showing he's a star, and I'll show. So everybody did a great job with this.
Dr. Richard Miller, chair.
All right, that's all I'm going to show. That way you have to actually go watch it. And then we also brought in nurses, because I think nurses are really a key part of this working. And so we have Caitlin and Kim Rosales talking about what you need to do. And they talked a lot about the policies, procedures, and what nursing staff can do. I think I have her on my, let me see if I can do this. No, I can't. All right. Anyway, you guys get on the link and you can listen to this. And what I can do is also just send the YouTube clips separately, so you could just go through and look at everybody. So, and this is a really multi-specialty audience that we're looking to engage. So OB staff, L&D staff, postpartum team, the pediatrics. And so we interviewed everybody representing our target audience, and everybody did a great job. So the other thing that we're trying to develop that you should stay tuned for is developing education. So not just educating the providers, but we feel like you need to educate the community, the moms too, because what I hear from a lot of pediatricians is they don't know how to discuss Hep B with patients because there's just overall a very low knowledge about hepatitis. So as I mentioned, people say, oh, but I'm not a drug user. Why do I have to do about this? Or, why do I have to worry about this? Or we even heard of another case at a hospital where the nurse was telling the moms not to get the Hep B vaccine because your babies are not having sex in the NICU, so don't worry about it. And so she was totally propagating the wrong message. But it's a little harder to talk about, some doctors find, than Tdap, right? So we're all giving Tdap during pregnancy and to the parents and household members. And people seem to be able to understand respiratory infections, but when you talk about hepatitis, people have a harder time understanding it. So what I usually recommend is linking it to liver cancer. Everybody understands liver cancer. So this is a cancer preventing vaccine. It was the first one, even before HPV. Nobody wants their baby to have liver cancer in the long run. So that is one reason, that is one way to go about talking about it. And so you'll be seeing some of these education materials. And we're hoping to have these flyers and also on like foam stands that will be on the table to educate parents about what hepatitis B is. So, and then one of the other questions we get a lot is, if we know for sure the mom does not have hepatitis B, why do all babies need to get it if I know for sure the mom doesn't have it? And so there's a number of things that people don't think about. The dad, we don't always test the dads. Babysitters, family that's visiting, au pairs from other countries. What I also mentioned is children that like to bite. So there are always other things where other exposures that a baby could get hepatitis B from. And one of the really good examples I had not thought about, but another mom mentioned to me, is that her baby ended up needing an emergent transfusion when he was just a couple days of age, and they had not anticipated it And they found out later, they got a report that the donor was found to have hepatitis B, or like the core was positive or something. It only came up later. And she said they were so worried that the baby got hepatitis B, but it turned out the baby didn't. But there was just that exposure they had not anticipated. So there are definitely iatrogenic ways of getting hepatitis B as well. And so sometimes we don't think about these things, but besides the mom, there are other exposures. And Hep B, as many of you know, is a lot more infectious than HIV also. So we want to just reduce the risk for all babies down to 0. All right, so in terms of cost effectiveness too, studies definitely show that perinatal Hep B prevention strategies, so including case management, testing, antiviral treatment, is very, very cost effective when you compare it to other preventative measures that we use, such as breast cancer screening, colorectal, and dual airbags. And even for adult hepatitis B screening, treatment, and vaccine, it's actually very doable. And a lot of people will use $50,000 as kind of like an intervention that is cost effective. So I encourage all of you guys to kind of join the No Hep movement. No Hep is what we hope to be kind of a global movement, like what the red ribbon is to HIV/AIDS, just to bring awareness to the whole world. And the No Hep website has a place for medical practitioners to join, to be visionaries, and to show that you're interested and invested in this endeavor. So thank you. My parting message is, let's give No Hep to the next generation. These are my 4 kids, and they're happy to say that they got the birth dose, and they're all Hep B free. So that's what we want to say. And I also just want to thank my whole team. If you guys want to stand up, they helped a lot with kind of making this whole possible. Wenshi, my navigator, with Brogdon, who's really been helping with the webinar, and then Bing is one of our volunteers who's been amazing as well. And obviously all the staff here who've been really instrumental in us kind of trying to move forward at St. Barnabas as well. And I'm happy to take any questions now. Yes. So yeah, let me go back to that. Actually, I realized that I didn't get to really talk about what we do in the preterm and the, okay, so this is the new protocol looking at birth weight, and so for the babies that are less than 2,000 grams, which you guys see a lot of in the NICU, if the mother is negative, you actually hold off on the vaccine. You can give it, but it doesn't count. So it doesn't count until they're stable and they're of the right weight. So you can give it at either at hospital discharge or at 1 month of age. And if they're unknown, if the mom's status is unknown at that time, you actually need to give the HBIG within 12 hours, regardless of weight. Oh, okay. I think the limitation has been weight. I don't know about I mean, obviously you have to do what you need to do to just keep the baby stable. So I think you stabilize the baby and then you give it. That's what I would say. If they're, I'd say, are you holding the vitamin K also at that time? Vitamin K you give anyway, obviously, because okay, I think that's something good to evaluate and see, in probably case by case scenario. Yes, Dr. Ye?
So what you might have mentioned is, what percentage of newborns after their first series
are not? That's a good question. They say the stats for adults are that after the first series, about 95% of people are immune. I don't know if it's any different for kids. But you know why? Because we don't check every kid afterwards. So, but because it's so high, 95%, it's not recommended to confirm immunity except for in these high risk babies where they're still exposed to an infected parent. But that's a good question. And the other question we get a lot from pediatricians is they're testing, like say they test college students or high school students, and they're finding a lot of them the surface antibody is low. But the CDC's recommendations that the titers can wane over time, but if you were ever exposed to Hep B, you would start mounting a response again. So they don't recommend checking just to check unless you're like us, you're a healthcare worker, and so you're considered more at risk, and we need to have confirmed immunity. Yes. So if the mom is unknown, so this is Hep B unknown, and this happens a lot. If there's, if they come in acutely and they don't have records, you have to consider them as surface antigen positive. So that baby needs to get a HBIG. A verbal I'm negative is not sufficient. So all these protocols that we're talking about, that Melissa was talking about, is that you have to have an actual documented lab copy on the chart for it to be confirmed. Or what we're saying now is, because we have the lab on site running the tests from 7 a.m. to 11 p.m., you just order it. You just order it, and it should be back in a couple hours. So, or you can order it stat so that you have it, rather than, because the HBIG is fairly expensive. It's several $100s per dose. So if we can actually get the mom's status before the baby is born, that's ideal. So that's a good question. If the mom is unknown and she refuses, I think a lot of it is how we present it also. But yeah, so you're saying, do you screen the baby at some point? And she has to get, is she refusing like regular pediatric vaccines too, like to do it at the doctor's office? Generally, I'd say in New Jersey, even though we're not doing great at birth dose, for the most part, babies are getting the Hep B vaccine series in infancy, before they start school, at least we know. So, but there's no protocol for screening babies unless the mom is positive. So I think you would then lump that kid into the mom is potentially positive. And usually what we do is we do a test after the vaccine series. And generally they say if you test about a year of age, that is a reliable indicator of whether the baby is infected or not. If you test too early, a lot of times it's the mom's surface antigen that you're still seeing in the blood. So yes, that's tricky question, because I don't know if the mom would be concerned enough to do the blood test. That's another thing with babies. We don't do blood tests that often. But that's why the 1 year of age works out, because that's when you're doing lead testing and CBC anyway. Yes. Yeah, it's still ultimately up to them to vaccinate. So, but I think what we're trying to move towards is opt out versus opt in. So just like vitamin K and erythromycin, we just consider it standard of care. And then they're offered, they can always opt out, but it should just be considered standard of care. But obviously, sometimes they listen to Dr. Google more, so. I was surprised when I was looking up erythromycin and vitamin K. I was like, all these websites about why you should not get vitamin K. And yet we had an incident, I think not long ago, of one of our pediatricians was at some conference where a baby who had not gotten, she was at a natural medicine conference, and a baby who had not had vitamin K actually had a cerebral hemorrhage in front of her. And she's a pediatrician too. And she was like, I can't believe I just saw this. Interesting. I'm sure. Yes, Dr. Ted. Mm-hmm. Right. Yeah. Right. Yeah. I'm sure. I don't know where they would have gotten that. I don't know where they would have gone then. I mean, I think this is a problem. People are forgetting why we have vaccines, and that's why there have been measles outbreaks, and people forget that kids, become permanently disabled when you have measles or polio, and people are forgetting why we have these interventions. All right, any other questions? Yes, Dr. Ye.
Well, I guess along those lines, there's less support for the argument that herd immunity will protect an infant from Hep B than the others. And
That's
the
true,
others
right.
were refusing vaccines. So, because it's in camp, I mean, it's already in camp.
Right, depends on their exposure, and it's not necessarily contagious in the same way that a respiratory illness is. But I think it's, besides just family, people forget about other exposures too. So other people that they're around that could also transmit. But yes. Yes. Breastfeeding, yes. So yeah, so breastfeeding on antivirals is an area where we need a lot more research on. So it has been found that the antivirals are excreted, like so tenofovir is excreted in breast milk, and the package says do not breastfeed. But I definitely hear from a lot of hepatologists and ID docs that they feel like the amount excreted is so minimal, and it's being ingested and not necessarily absorbed in the baby's system. So some specialists will actually say it's okay, but the general recommendation is that until the mom stops breastfeeding, or until the mom stops the antivirals, then you wouldn't breastfeed. All right, thank you, everybody. Hey, how are you?
Very good.
You were on last night, or?
No. I'll be on tomorrow.
So did Anso get,
Yes.
I ordered
yes,
the CT,
yes,
okay,
yes.
all right, good.
So there is a possibility.
Oh, you are
Whether
excited.
we're going to, there's another possibility. They do an MRI there.
Oh, in Taiwan,
We'll see.
yeah. I have a lot of patients do that. Just make sure, she keeps a copy of it for me. All right, see you.
Sue, thank you very much. That was very good, very informative, and I think that would, I think that was just perfect. So
So,
hopefully,